Can you start the Russia?
أسماء ازيك؟
Can you please start the Russia?
نعم.
Can you please start? We are broadcasting now. Can you please start?
I'm just looking at the attendees. Yes, we will start right now. Good evening, everybody. I would like to welcome you all to our second webinar for Qasr al-Ain Pediatric Ophthalmology. Today we have 4 very interesting talks, and I'm glad that we have today Dr. Ghada Gawdat and Dr. Dina El-Fayoumi as our moderators. We will start with Somayya, who will present our first talk. Somayya, you can share your screen, please.
Okay, good evening, everyone. I will discuss today a case of Axenfeld-Rieger anomaly. A 4-year-old male child presented to us by bilateral congenital glaucoma and history of bilateral congenital surgery twice, and he is on medical anti-glaucoma treatment and has positive family history. A mother and 2 siblings shows a similar ocular problem since dating since birth. A general examination, apparently healthy child with no abnormal features or systemic disorder apart from bilateral megalocornea. Ophthalmic examination relieved right eye visual acuity was 160, and the cornea clear and posterior peritoxin, and iris has stromal hypoplasia and corrective and polychoria. IOP was 18, and central cornea thickness was 480, and this coming 0.9. Left eye show hand motion and the cornea totally opaque, and the iris couldn't be assessed. IOP was 12, and center cornea thickness was 600, and this couldn't be assessed. Anterior segment OCT of the right eye show iris strands adherent to anterior displaced Schwalbe lines, and left eye fluid angle. Another picture show anterior segment photography, show lens glaucoma and iris stromal hypoplasia and correctopia. And old sister has anterior displaced Schwalbe lines. Anterior segment OCT show the right eye show broken and anterior displaced posterior peritoxin, and left eye show occluded angle by peripheral anterior synchyme. So the differential diagnosis is Axenfeld-Rieger anomaly. Posterior peritoxin normally occur in 15% of cases of normal population. Axenfeld-Rieger anomaly. Axenfeld anomaly show posterior peritoxin and iris strand adherent to anterior displaced Schwalbe line, and Rieger anomaly congenital iris abnormalities, hypoplasia, and polychoria. Rieger syndrome, Rieger anomaly plus systemic associations, facial bone defects, including maxillary hypoplasia, umbilical and dental abnormalities, and pituitary involvement. Axenfeld-Rieger syndrome include Axenfeld anomaly plus Rieger syndrome. The second differential diagnosis is iridocorneal endothelial syndrome, usually unilateral condition and sporadic, and it's acquired affect middle-aged woman, and there is no posterior peritoxin or hammered silver corneal endothelial changes, and the iris is atrophic and with no systemic associations. Peters anomaly presented with central corneal opacity and defective desmid, and there are two types: type 1 affecting cornea alone, and type 2 affecting cornea and lens. And the sex of cases bilateral and associated with congenital glaucoma with or without systemic associations. The fourth differential diagnosis is aniridia, is presented bilateral, autosomal dominant, and 30 of cases sporadic, associated with a mutation in PAX6 gene, and has risk of 50 and 75 risk of glaucoma, associated with corneal planus and foveal hypoplasia and iris hypoplasia. So the diagnosis is Axenfeld-Rieger anomaly plus secondary glaucoma. genetics associated with mutation in 3 genes, FOX1 and PITX2 and PAX6 gene. It's autosomal dominant with variable expressivity and high penetrance. Epidemiology, there is no gender predilection, and 50% risk of glaucoma appeared during childhood and early adulthood, related to the height of iris insertion. It's occurred due to defective neurocrystal-related processes during fetal development, occur in 1 per 200,000 live births. Medical management used as adjunctive to surgical intervention, equisuppressants including beta blocker and carbonic anhydrase inhibitors, and prostaglandin analog, alpha-2 agonists, primidine and apraclidine are contraindicated in a child less than 2 years due to potentially serious apnea, bradycardia, and CNS depression. Surgical management, as in congenital glaucoma, surgical intervention is more effective than medical management. However, achieving long-term surgical success is difficult and complications are common. Surgical options include goniotomy, trabeculotomy, trabeculectomy, plus or with or without antifibrotic agents, glaucoma drainage devices, and cyclodestructive procedures. The surgical outcome of glaucoma-associated Axenfeld-Rieger syndrome. In retrospective cohort study, at university hospital-based practice of patients diagnosed with Axenfeld-Rieger syndrome in USA in 2020, the goal of the study to compare effectiveness of surgeries of surgical management in Axenfeld-Rieger syndrome. The success rate and survival rate were assessed. Success was defined as IP 20 millimole mercury and no additional IP lowering surgeries. It's done in 32 patients identified with Axenfeld-Rieger syndrome. Goniotomy showed success rate 43%. Trabeculectomy with antifibrotic shows success rate 57%. Trabeculectomy plus or minus trabeculotomy shows success rate 17%. Ahmed valve placement shows success rate 25%, and Perceptual device placement shows success rate 70%. And cycloablation show success rate 33%, but there was no difference in number of glaucoma medications. Take-home message: Axenfeld-Rieger anomaly consists of posterior imperial toxin and iris strands adherent to anterior displaced line and iris abnormalities. It's an autosomal dominant disease with variable expressivity and high penetrance. It's a bilateral condition associated with 50% risk glaucoma. Management mainly surgical, including trabeculectomy with mitomycin C, and the glaucoma drainage devices have higher success rate. Thank you.
Thank you, Somayya. Dr. Ghada and Dina, would you like to discuss, or do you have any questions?
Yes, I think I do. Somayya, if you haven't seen the mother or her or his sister or her elder brother, would you consider him as an Axenfeld from the start?
Yes, has a sister.
Because the anterior segment photography is not that classic in this child.
His sister, anterior segment photography show bilateral displaced posterior imperial toxin and iris abnormalities. So she is Axenfeld-Rieger. No.
I mean, if he comes to you alone on his own, would you consider him as an Axenfeld from the start? I think the clue was his mother and the history she gave to you, because she is Axenfeld and think his sister and his elder brother as well, right?
Yes.
Okay. Dina?
Yes, thank you, Somayya, for the presentation. I would like to ask, did the handheld OCT help you in the diagnosis of such case? because as Dr. Ghada said, the presentation or the clinical picture of the boy without seeing his family wouldn't suggest that he is an Axenfeld-Rieger anomaly. I would rather think of a primary congenital glaucoma if I don't see his family or know the history of his family. So when doing the handheld OCT, did this help in the diagnosis?
Yes, it show iris strand attached to a displaced Schwalbe line and show posterior embryotoxin or shown clinically.
I believe that his sister had more typical findings than him.
Yes.
Photos that you displayed.
I would like to ask you another question. Do you think that this is a typical age for presentation of glaucoma for such a case? Is this the usual age for an Axenfeld to present with glaucoma at that age?
It's more in adulthood and childhood than in 4 years.
Okay.
Thank you. Thank you, Somayya.
Thank you, Somayya. Our next presenter is Dr. Pola. Pola, can you please share your screen?
Good evening, my dear professors and colleagues. Today I will present a case that we saw in Elreesh clinic. 11-year-old boy came to us complaining from a hypopigmented spot inside his left eye. Other than that, the child is completely asymptomatic, and this is a picture of his left eye. By reviewing the patient history, there was no history of any systemic medical illness. The patient gave a history of the trauma by pencil to the left eye 3 years ago, causing a corneal rupture that repaired at Qasr Aini emergency room. His parent noticed this spot 7 months after corneal wound repair. On the patient examination, the uncorrected visual acuity bilaterally was 6.6, and this is his refraction. And the IP was 12 and 14, and the pupils was round, regular, and reactive, and the patient with a free ocular motility and normal muscle balance. Anterior segment examination of his right eye was completely normal with a clear cornea and a clear lens and the normal color and pattern of iris with a normal depth and no abnormal content of the anterior chamber. However, anterior segment examination of his left eye showing a cornea, showing a superior corneal scar that extending from 10 to 12 o'clock parallel to the limbus as showing in this picture, and the lens showing a faint anterior and posterior subcapsular cataract, and the iris showing a large iris mass superiorly and irregular depth of the anterior chamber. And this is a large photo of this iris mass. Posterior segment examination, the patient has a bilateral normal fundus. Now, how to think about this iris mass? First, we should know what's the differential diagnosis of any iris mass. Any iris mass may be cystic and may be solid. Maybe cystic mass like a primary iris pigment epithelial cyst or primary iris stromal cyst or epithelial downgrowth. Maybe solid mass, melanocytic or epithelial, melanocytic like nevus, melanocytoma, melanocytosis, lesion nodules, and iris and cell body melanoma. It may be epithelial like iris pigment epithelial adenoma and medulloepithelioma. Now we requested the investigation to know is this mass cystic or solid. We requested the UPM, and UPM showing a lot of information. The anterior chamber depth is irregular, showing an iris cyst that detected superiorly, and then evidence of a well-capsulated iris cyst that attached to the back of the cornea and containing a clear fluid, with an acoustic evidence of the normal angle and the normal ciliary body all around. Now we have a cystic iris mass. Looking back to our differential diagnosis, a primary iris pigment epithelial cyst or primary iris stromal cyst or secondary to the epithelial downgrowth. So it is a cystic iris mass, most probably secondary epithelial downgrowth following trauma. Now let's talk in brief about what is the classification of the iris cyst and when to interfere or how to manage the cases of the iris cyst. First, we'll talk about classification of iris cyst. Iris cyst may be primary, may be secondary. Primary iris cyst like iris pigment epithelial cyst or iris stromal cyst, or maybe secondary epithelial downgrowth post-surgical or post-trauma, or cyst secondary to the intraocular tumor like iris melanoma or medulloepithelioma, or maybe secondary to the medication like miotics and prostaglandins. Now, how to when to manage this case? When associated with complication, and usually the complication depends on the size and the location and the compression of this cyst to the adjacent structures. And the reported complication is a corneal decompensation and angle closure glaucoma and cataract and lens subluxation and iritis and pigment dispersion syndrome or obstructing the visual axis. How to manage the cases of an iris cyst? Let's take about general rules that the cysts that are stable and not causing any symptoms or secondary complication, so no treatment but just regular follow-up. However, the large iris cysts that involve the visual axis, especially in children that are at risk for the amblyopia, usually require an early intervention. Usually start by step-by-step approach, starting with a conservative, less invasive treatment than invasive surgical procedures. By reviewing the literature, we found many management options like laser. We can use argon laser photocoagulation of the cyst epithelium to shrink the cyst, but in these cases, the recurrence is common. We can also use a YAG laser cystostomy of the cyst wall that may allow the perforation of the cyst and release of the content into the anterior chamber to collapsing the cyst. Another option, that cyst aspiration and injection of the sclerosing agent like alcohol or mitomycin C, and in reported case, the recurrence is not by this management option. We can also make an implant surgical excision of the cyst, but this is an aggressive surgical approach of the iris cyst without like cryotherapy. While this procedure has a good success rate, but has a greater risk of causing the collateral damage to the other ocular structures. So take care, a secondary iris cyst due to the epithelial downgrowth may require a more aggressive surgical excision and revitalization of the epithelial tissue with vitrectomy, lensectomy, and the cryostructure of the residual cells at the excision sites. Backing again to our case, the cyst is asymptomatic, not affecting the visual acuity, the uncorrected visual acuity of 6/6, and not causing any complications, so no treatment, but just close and regular follow-up for this patient. So our take-home message is a proper assessment of any iris mass in children, close follow-up of the corneal wound due to the epithelial downgrowth, and if the iris cyst present causing any complications, not causing any complication, do not interfere, or if causing complication or affecting the vision, interfere. And this is our reference, and thank you for your attention.
Thank you.
Thank you, Pola. I would like to ask our panelists and Dr. Ghada or Dina if they would like to ask any questions.
Pola, thank you so much for the nice presentation. It's really very interesting. And you are very wise not to interfere in this patient, actually. But I have a few questions. You said you can use lasers, whether argon or YAG lasers. Just tell me, how would you apply lasers to this cyst? Because the patient has vision 6/6, and the cyst is between the cornea, back of the cornea, anterior surface of the iris. And how would you apply argon laser or YAG laser?
In this case, we wouldn't interfere to the patient by laser or any surgical procedure, as the patient vision is uncorrected vision is 6/6. So in this patient, we do not interfere. But generally, in laser, we can apply laser to just make an opening in the cyst to release the content and allow collapsing of the cyst wall. Then applying the photocoagulation around on the cyst wall, anterior and posterior cyst wall, and around the cyst to the iris.
Won't you be scared of the releasing the contents of the cyst, that it might initiate an inflammatory action of the AC?
Yes, many reports.
So you're prepared. You're prepared for this.
Yes, we prepared for the severe inflammatory reaction, and in many reported cases, they started to give the patient steroids and anti-glaucoma even before 1 week before the laser.
Prior to the photocoagulation.
Yes, and continue after the photocoagulation or laser iridotomy.
Another thing that you mentioned is that you inject mitomycin C inside the cyst.
Yes.
You know, we get scared of mitomycin C, and when we get mitomycin C in glaucoma surgeries, for example, we keep washing and washing and washing.
Yes, and in this technique, we also washing the mitomycin.
What's the concentration?
0.0002 per milligram, and we injecting 0.2 milli inside the cyst and leaving it for 5 minutes. Then we washed, then re-aspirating again the mitomycin and wash with a balanced salt solution at least 5 times.
So you target the epithelial cells inside the cyst, you want to destroy them, and then you apply aspiration of the cyst contents. Yes, this is excellent. Yes. Have you ever tried mitomycin C inside the cyst?
No.
I've tried it once and I used it. Yeah, I was scared of having a heart attack, so I did not use it again. Although it worked beautifully and it was fine, and the patient got relieved of his cyst and everything was okay, but it's scaring a bit.
The only reported cases with no recurrence after using this technique is cyst aspiration and injecting of the sclerosing agent, however, an alcohol or mitomycin C.
Yes. So you chose not to interfere, and this was very wise.
Yes.
Yes. Thank you, Dina.
Pola, thank you for the very interesting presentation. I would like to ask you, you chose to keep close monitoring for the patient as a choice for the treatment. What is the most important thing that you would like to monitor in this patient in particular?
In this patient, I fear about this iris cyst that may enlarge and obscuring the visual axis of the patient. And in this case, we should interfere as the patient is at risk of amblyopia.
Do you think enlargement only is the only thing that you will fear of? Aren't you afraid of the attacks of iritis, recurrent attacks?
Yes, the complications that I mentioned, the patient may go to an iritis or angle closure or pigment dispersion or the many other complications or corneal decompensation from the touching the back of the cornea to the touching the endothelium.
So you mentioned a lot of methods for the treatment or the management. Do you think, how can we prevent this complication from happening from the start? Because this is a very commonly seen complication following rupture globe or following the repair seen in the casualties. So do you think we can prevent it from the start from happening? Is it a preventable complication?
Only the preventable, we can suturing the wound very well and keep an eye for any patient with a corneal wound repaired for it may happen to a patient have an iris cyst at any time.
What you mentioned is very important, is the proper suturing of the wound.
Yes.
Because the posterior wound gaping, which is seen very frequently post traumatic ruptures, we see a posterior wound gape which allows the epithelial cells to creep inside the anterior chamber and perform these epithelial ingrowths, and we see this complication later on.
Yes.
Thank you, Paul. Thank you.
Thank you. Thank you.
Thank you, Paula. I just want to point out that obviously when we see these cases like in the clinic and we see it in the pediatric age group, some of these children are of course very young and they will not sit on the slit lamp so that you cannot perform for them YAG or argon laser, and that one of your inevitable options that you have to perform surgery for them. As you mentioned, that sometimes you may require some aggressive treatment, that you need to remove the cyst and do a vitrectomy and remove part of the iris. And I think as advice that this should be handled by an experienced surgeon so that we can do less damage than we intend to do. Dr. Ghada, إيه رأي حضرتك? What do you think?
I totally agree, but actually the visual acuity is the cornerstone of this whole issue, because I've tried it before several times actually. When I tried to go inside the cyst and I tried to remove it, and I did cyst removal, and then I did iridoplasty, and it was a beautiful surgery. But that patient had vision of 618 then. I left him with vision 360 after that surgery. So I stopped completely interfering in patients with good vision. If the iris is not increasing in size, if the cyst is not increasing in size, and he has good vision, I have to monitor and keep conservative treatment. The second case, we just had 2 weeks ago. This patient has been following up with us since 8 months, actually. She presented for the first time with a traumatic epithelial cyst like Pola's case, and she had vision 612 that time. So we refused totally to touch the patient. I refused because I was actually, I had a previous experience from an epithelial cyst before. So I refused to touch her. Till she came recently, a month ago, and she had dropped visual acuity because she developed cataract as well. And the cyst had enlarged and it was obstructing all the visual visual pathway for her. Pupillary area was blocked with the epithelial cyst. So I removed the cyst. I did like what Pola did. He did not do that, what he said. I aspirated the contents and I removed the walls of the cyst. I demercialized it. And then I removed the cataract and I implanted the intraocular lens, and the girl is enjoying good vision, alhamdulillah, till now. Yeah. Hopefully she stays like this, inshallah.
Inshallah. Thank you, Pola, Dina, and Dr. Ghada. We move on to our next presentation, Asmaa. So, Dr. Asmaa, can you please share your screen?
Okay. Okay, good evening. Gives me pleasure to present you today this study that we've done 2 years ago on pediatric aphakia with no capsular support, in which we've compared two techniques, the sutureless scleral fixation to the iris glow lens that is retropupillary fixated. This subject is of great importance in children because they have longer life expectancy. So if they don't have a capsular support, there will be lots of things to take care of. The main options that we have is to do a scleral fixation or iris glow lens technique. So the iris fixated lenses, they include the iris sutured and the iris glow lenses. In pediatric age group, we had only one study on the iris sutured type, and we had lots of studies on the iris glow lenses, even the anterior and the posterior fixated types. But the anterior fixated type has that problem that is well known, which is the endothelial cell loss. So we had the retropupillary fixation technique that was introduced in the year of 1994 to avoid the endothelial related complications. And now moving to the scleral fixation technique, we have the sutured and even the sutureless. The sutured, we know different techniques, the ab interno, ab externo, the Hoffman pocket, and even the Gore-Tex with the Acryos IOL. And now we have the four-flanged technique. So these types of surgeries, they have multiple complications that are related to the sutures that may cause erosion with time and even get exposed, or even you cannot bury it, and even you have the breakage of the sutures. So in the year 2007, we had the sutureless scleral fixation technique that was introduced by Sharios with multiple modifications done by Agarwal. So these techniques, they have multiple, what can we say, modifications to do regarding the tunnel, the tunnel construction, the haptic exteriorization, and even the flap closure. So regarding the tunnel construction, we have the technique with a flap and even no flap, and even with the Y-shaped tunnel. The haptic exteriorization can be done with a forceps, with a suture, and even with a needle, like the Yamani technique. And we have the flap closure that can be done either with a glue or no glue. So the aim of our work is to compare these two techniques in children who have no capsular support, and we included 30 eyes of 17 patients in Elreesh hospital. But these children ranged from the ages 3 to 14 years old. We even included the cases of severely subluxated lenses, and we excluded the cases with penetrating eye trauma and the uncontrolled glaucoma, severely damaged iris, because at this case we cannot do an iris glow lens, and in the cases of uveitis and macular lesions. So we're divided into the two groups, and we've done the preoperative assessment regarding the best corrected visual acuity, slit lamp examination, the intraocular pressure. We've done the central corneal thickness and even the specular microscopy. We've done a posterior segment examination with macular OCT in order to identify the thickness of the macula. The IL calculation was done with optical biometry, and here we have a very important point to stress on, the A constant. In the suture, the scleral fixation, it's a posterior segment, not a posterior segment, I mean, it's at the level of a sulcus, or it's behind the iris. And at this condition, we will use an A constant of 118.4. And we know that the anterior chamber IOLs have A constant of 115. But the important point to identify is in the retropupillary iris clove lenses, we will calculate the biometry using an A constant of 116.8, because it's not an anterior chamber and it's not a posterior chamber completely. So it's midway between them. So the surgical technique itself, we will start with the scleral fixation technique. Actually, the most important first tip and trick is that you will construct your flaps to be opposite to each other. The upper flap is is limbus based, and the lower flap is fornix based, so that you have better exposure. And after forming the flaps,
I'm sorry, is the video working? Is the video working?
Okay, it's working here, so I will share it. Okay.
Okay.
Okay, just a moment. Okay, here you can see it.
Yes, we can see it now.
Okay, so regarding the sutureless scleral fixation, it's very important to construct the flaps directly opposite to each other. So the first flap or the lower flap will be fornix based, while the upper one is limbus based. For better exposure. And after forming the flaps, you will form the tunnel. You can construct it with an MVR, and it's better to do it with an insulin syringe so that you will have a very tight tunnel. Using an infusion, a trocar with an infusion is very important in these cases to keep the globe formed while doing lots of manipulations. So after you make the wound, you will introduce your 23 forceps for the lower sclerotomy, and it's a serrated forceps. And then you will introduce the IOL with the right hand, hold the injector, and the nurse will do the scrolling. The most important tap in here is to hold the haptic from the tap, and it has to be the tap and not any other part of the haptic in order not to break it. So after exteriorizing the lower haptic, the nurse will keep scrolling till the IOL is completely free inside the eye. And the nurse can hold this haptic for you if you're feeling that you're not secure enough. And for the upper haptic, with a handshake technique, you can get the haptic inside the eye and then give it from one forceps to another, and always hold the haptic from the tip, as we can see in here. So here we've got the tip. And in order to get the haptic inside the tunnel, always hold the haptic from the tip and not any other part of the haptic in order not to break it, okay? So this is the lower haptic. Here, I'm going to pull it inside the tunnel. So the pulling is better than pushing, because you don't know if you're inside a false passage, and you don't want to get the haptic kinked. You want it to be completely tucked inside the tunnel. So it's better to pull it and not to push it inside. And after getting the haptics inside the tunnels, you can watch the proper centralization of the IOL. Here we've got this haptic and the upper haptic, and the IOL is completely centered, and then close your wounds. So this is the scleral fixation. And now moving to the iris claw lenses, you will construct a wound of 5.5 millimeters to introduce the IOL. The IOL has to be flipped so that the curved side is facing posteriorly in order not to have a pupillary block. So rotate the IOL, it will be in the horizontal position, and use the forceps of the IOL to make a very good grip. Don't dilate these cases. So, and now the first haptic is introduced below the iris with inclination, and then the second haptic will be introduced with inclination using a Sinski hook. Inclavate the mid-periphery of the iris, not so central and not so peripheral, in order not to get ovalization of the pupil. So regarding these patients, we've done the post-operative evaluation at the first day, the first week, the first month, 3 months, and 6 months. We did all the examination. We repeated the examination all the times. But at the third month, we've done the UBM and the specular microscopy and the macular OCT at the 6 months. With the UBM, we've done the IOL decentration. We've calculated the decentration and the tilt of the IOL. Basically, these techniques depend on having a line between the two scleral spurs, and then we will identify the position of the IOL according to that line. So the results of these surgeries, or the study, first of all, we are going to talk about the operative time, which was statistically significant. We had a statistically significant difference. The scleral fixation group had shown a significantly longer time. And the intraoperative complications in the scleral fixation group, we had 1 case of broken haptic, 4 cases of haptic. If you're doing lots of forces, of pulling forces inside the surgery, you will have a slipped haptic. And 1 case in which we had to enlarge the wound to the manipulation of the IOL. The iris claw lens had 1 case of hyphema and 1 case of iris injury while constructing, making the PI. So I forgot to talk about this point. It's optional to do a PI or not in the case of retropupillary iris claw lenses, but we've done PIs in order to prevent any incidence of glaucoma in these children. So the postoperative outcome, the best corrected visual acuity between both groups had shown no difference. The change in best corrected visual acuity also had shown no difference. Regarding the astigmatism, it was higher in the iris claw lens, but in the iris claw lens group, but in the end, they had reached the same level with no difference at the 6 months. And the intraocular pressure, it's also with no significant difference. Regarding the complications post-operative or the intraocular pressure, in the scleral fixation group, we had 1 case of hypotony, and in this case, we've waited. It improved within 2 weeks, and 2 cases of glaucoma, which were managed medically. In the iris claw lens, we had also 1 case of hypotony, which improved spontaneously. And we had 1 case of, and we had also a case of glaucoma that was controlled with scleral trabeculectomy, but actually this was mainly, or we think that it was affected glaucoma, it's related to the IOL itself. So regarding the IOL decentration and tilt, there was no significant difference between both groups. And the corneal affection regarding the change in the central corneal thickness, there was no difference. And the change in the endothelial count, no difference also. And regarding the change in the foveal thickness, also we had no difference. So the post-operative complications that we've seen in the scleral fixation group is a decentration of the IOL in 4 cases that we had to operate on them. We had a subconjunctival haptic with no erosion. We had a peaked pupil in 3 eyes, mainly due to having a vitreous strand in the wound. We had an IOL capture that was managed only with eye drops. We had an inflammatory membrane that was managed with YAG in one case. In the iris claw lens, we had irregular pupil. It's ovalization of the pupil that we can see in here. And to avoid this, just enclavate the mid-periphery of the iris and not so central, and not enclavate the central part or even a peripheral part of the iris. And a trauma, but this is really related to the using a vitrectomy probe during the surgery and not to the IOL itself. So we had an IOL haptic piercing the iris. We had also patches of iris atrophy. And we had this enclavation in 3 eyes that we had to go for another time to re-enclavate them. And one of them was after a glaucoma surgery. So we had post-operative inflammation after this enclavation. We had retinal detachment in one eye and hyphema, which is due to creating the PI. So this study is the first study to compare these two techniques, the visual outcome, and the different outcomes we had in here were comparative to other authors. And the operative time was previously mentioned, and it was shorter in the iris claw lens group or the iris claw lens technique by other authors, but the scleral fixation, we were the first to talk about the operative time in here. The central foveal thickness had shown no changes in contrast to other authors who had reported macular edema. So in conclusion, these two techniques, they are comparable to each other, but the scleral fixation technique needs longer time with a longer learning curve. And so if you want to decide which of them to use, that would be according to the surgical preference, the preference of the surgeon himself, the cost of the IOL, and according to the financial situation of the patient. So we had suggested having this type of an IOL for the scleral fixation technique of longer haptics that may add to this technique. Thanks a lot for your listening.
Thank you, Asmaa. A very interesting study, a very tough one as well. Dr. Ghada and Dina, and also the panelists, if they would like to ask any questions.
I would like to ask Asmaa a few questions. First, with all the techniques, the new techniques for a sutureless scleral fixation, do you still find a place for the conventional scleral fixation using sutures?
Yes, yes, I use it. Sometimes, yes, it's still there. You can use the suture techniques. Yes, you can use them. And there is a situation in which you cannot use a sutureless technique. If you have one point fixation at the situation, you won't be able to use a sutureless technique because you would have an IOL decentration. So you have to go with the sutures, yes.
Do you consider scleral thickness in such patients, or in some patients having scleral thinning, in doing tunnels, for example, as a technique for sutureless scleral fixation?
Okay, I did not try that, but if we have this problem, I think we can go for an iris claw lens.
So another thing I would like to ask you, when we choose these techniques for children, especially the tunnels, I mean, children do have a growing globes, growing eyes. Do we consider that or take that into consideration when these globes grow, the decentration or the IOLs becomes more evident by following up these children related to the growth of the globe with age?
Well, actually, I did not see decentration or disenclavation in these patients till now. And while you are constructing the tunnel, it has to be about 2 millimeters from the limbus, not very far away, so that it won't be that the haptics will not be that so stretched. And in these patients, I did not see like decentration or slippage of the IOL, in which the patients in which the IOL was stable from the start and they did not receive any trauma, it's still stable. But actually, the patients with the iris claw lenses, I've seen more disinclinations because they have lots of movement, and you know, the children, you know, they move all the time.
Okay, then when you see haptic migration, especially subconjunctival, because a lot of cases we see nowadays following up post-surgical intervention, do you interfere for such haptics, and do you fear from any infection?
No, actually, you don't. If you don't have any erosion and you don't have any infection that is evident, just leave it. Just leave it.
Even if you see haptic subconjunctival?
Yes. Don't interfere with that. This is my experience and the things that I've learned from my professors, but we don't interfere in that. We don't cover it. Yes.
You mentioned that you had one case of retinal detachment in the study. Do you recall the cause of the retinal detachment? Was it a predisposed case from the start? Was it, for example, a Marfan syndrome or having any retinal pathology? Or was it related to a complication that happened to the lens post-op?
Well, it was a case of disinclination. So after we re-inclavated the IOL, we had a detachment. So most probably it's related to the manipulations that we had in the surgery.
But the child was examined, the retina was examined properly before the surgery, and there was no underlying pathology or retinal pathology?
No. But the detachment happened after the second surgery, after the re-inclavation.
Okay. Thank you, Asmaa. Thank you.
You're welcome.
Asmaa, I have a few questions for you as well.
Okay.
I need to know, you said there's no statistically significant difference in the tilt or in the IOL decentration between both groups, right?
Yes.
I thought that the retropupillary iris fixation definitely should be more stable and should be more centralized than the scleral.
Yes, it's by logic, but regarding the numbers, having a statistically significant difference, it's related to the statistical tests, the numbers themselves.
No, I mean the mechanism of fixing the retropupillary lens. You cannot measure the IOL tilt or decentration by UBM as you did with the scleral tunnel fixation, right? It's totally different.
It's totally different, but we compared it, yes.
Okay. And I need to know if there is the point where you enclavated your haptics in the retropupillary. You said ovalization happens when you implanted in the middle of the iris diaphragm, right?
No. You have to enclavate the mid-periphery of the iris or the middle of the iris, and not to be that so peripheral and not to be that so central. You will have this stretching or ovalization. It improves with time, but it will be still there.
Okay.
In the end, it's not a very big problem as long as the patient is seeing and you don't have any glare or a problem, but you know, it's disturbing.
Sometimes the parents get so much disturbed because of the ovalization of the pupil. They think this is an abnormal outcome of the surgery.
Okay.
Actually, I found out that when we fix the haptics at the junction of the outer 1/3 and the inner 2/3, because this is the junction between the immobile part of the iris and the mobile part of the iris diaphragm. The iris is not totally mobile. The medial 2/3 only are mobile. That's why we try to avoid medial part, the central part of the iris. Thank you so much.
Okay.
Thank you for the nice presentation.
You're welcome. Thank you.
I have one question. You mentioned that also the condition of the iris is very important. And I think you mean by that, not just whether this patient, for example, the iris is not regular, or sorry, the pupil is not round, regular, or active. I mean the condition of the iris regarding the iris pattern, right?
Yes, if you have iris atrophy, like a case of trauma, and you have this degree of iris atrophy, you cannot enclavate it. You have to find healthy irises to enclavate within the haptic of the IOL.
Because I had one patient where I did the sutureless scleral fixation, and The iris was very flail. He was myope. And what happened in this patient actually is that one time he came for follow-up and it was retropupillary sutureless scleral fixation, and then he came and the optic was anterior to the iris. And then I was like, okay, I'll follow him up because his vision is still good and clear visual access, everything was quiet. And then he came on the second follow-up, and the IOL was behind the iris, and then another follow-up, the IOL was anterior to the iris, and it kept going at anterior and posterior, and I realized, and that was the fault of the iris was very, very flail. It was really floppy, so sometimes it just moves back behind the lens, sometimes it moves anterior to the lens, and I decided not to interfere at all.
Okay.
Anything like this before.
Yes, I've seen one case in which the optic was captured once, and actually the mother had noticed a very funny thing. She told me he was in a dark room, and after that he went out with the IOL captured in the pupil. But actually what we've done is I've given him Mydriatic eye drops, cycloplegico, and we stayed together in the clinic. And actually, the IOL was not captured anymore. But the only explanation for that by my professor, Dr. Ahmed Mustafa, he told me maybe we implanted the IOL slightly anterior. Yes. So yes. So we had this capture, but it happened once. Luckily, it happened once, and it went back with just doing giving the patient mydriasis, so it was not captured anymore. And when the pupil closed, it was not captured.
Thank you.
I think the problem in your case, Russia, was the iris, not the IOL, right?
This patient was he was myope, he had a large globe, and the iris was extremely floppy. And I realized that the iris was, it wasn't the lens that was constantly moving,
Yes.
it was the iris that was moving anterior and posterior to the optics.
Yeah.
It's maybe because also the high myopes patients, they have this voluminous size of the anterior chamber, so the iris was not like stable like other patients.
It was a flail iris.
Yes, yes.
Thank you very much.
So thank you.
I would like to move forward to our next speaker, Dr. Heba Fouad, and a very interesting topic. And Heba, you can share your screen, please.
Okay.
Yes, you can start the the slideshow.
Okay, can you see the presentation?
Yes.
Yes, it's not in the slideshow.
Okay. Start the slideshow.
Yes, okay. Okay. Here, I will present recent updates on the diagnosis and management of amblyopia. Before I start, I would like to thank my dear Professor Dr. Ahmed Rida Awadin and Dr. Dina El-Fayoumi for helping me in the content of this presentation. Amblyopia is defined as reduction of best-corrected visual acuity, contrast sensitivity, and binocular deficit that cannot be attributed exclusively to a structural abnormality of the eye. It's fairly common, affecting 1 to 2% of children in the USA. 3 studies were conducted in Egypt as well, and they found out that the percentage was 1.5 to 2% as well. 1.2% of these children lose their vision in the sound eye secondary to trauma, unfortunately. It's the most common cause of reversible visual impairment in children. The causes of amblyopia are anisometropic, strabismic deprivation, or mixed. The fundamental rules for visual development are adequate stimuli from both eyes, corresponding images, and integrity of the visual pathway during the critical period of visual development, which is crudely defined as the period from birth to 2 years of age. Diagnosis of amblyopia. Screening time, the key to treatment success of amblyopia is early detection. The U.S. Preventive Service Task Force recommends visual screening in children 3 to 5 years old. However, the APIS recommends visual screening at 6 months to 3 years, and recently they even suggested screening at 3 months, but there's still no evidence about the cost effectiveness of this early screening. The screening tests are either tests that detect amblyopia or tests that can detect amblyopia risk factors. The tests that can detect amblyopia itself are the visual acuity test. they have a subjective component. They need cooperation from the child, so they're not suitable for children younger than 3 years old. In the last 20 years, the Pediatric Eye Disease Investigative Group has conducted randomized clinical trials to address amblyopia. Minimal duration of each study was 8 to 12 weeks. The studies are evidence-based. PEDIC studies use the standard visual acuity testing protocol. They use the HOTV letters for children 3 to 6 years old, and they use the ETDRS test for older children 6 years and older. They defined amblyopia as mild, moderate, and severe. Mild amblyopia is defined as visual acuity of 20/30, less than 20/30 or 20/30. There's a great controversy if this is even considered as amblyopia. PEDIC studies excluded mild amblyopia from their studies, and all the studies were performed on moderate and severe amblyopia. Moderate amblyopia was defined as visual acuity of 20/40 to 20/80, and severe amblyopia was defined as visual acuity 20/100 to 20/400. The tests that can detect amblyopia risk factors are photo screening tests, autorefractor tests, and fixation tests. The photo screening tests or the eye screen use the red reflex to estimate refractive error and identify the amblyopia risk factors such as strabismus or media opacity. The autorefractors estimate refractive error only. The plus optics assess both photo screening and autorefraction. Pediatric vision screener or the blink tests the binocular retinal polarization or scans the central fixation. So it detects any paracentral fixation. The Go Check Kids app iPhone application was tested in the APIS last January, and it was effective in screening of amblyopia for infants as young as 3 months. Treatment of amblyopia and prevention through early detection, treatment of the cause, such as treatment of strabismus, ptosis, media opacity, and treatment of amblyopia itself. There are many traditional and novel methods to treat amblyopia. They are either monocular or binocular. The traditional monocular methods are mainly the occlusion, atropine, polarization, binocular gyroscope, and phenolphosphor. The novel techniques are mainly binocular, which is the Coptic training, but there are some monocular therapy as filters and perceptual learning. The earlier the detection and treatment of amblyopia, the better the visual outcome, as in children 3 to 7 years old, there is complete resolution in 75% of children, and this resolution decreases with age. Refractive correction alone by spectacles, as stated by the amblyopia treatment study 5, anisotropic amblyopia, there is complete resolution in 1/3 of cases. In strabismic amblyopia, complete resolution in 1/4 of cases, and in refractive amblyopia, there is complete resolution in 75% of cases. So amblyopia therapy is not required until trial of spectacles alone first. Patching is an effective method for amblyopia therapy. The number of hours vary based on the whether the amblyopia is moderate or severe. 2 hours of patching in moderate amblyopia is as effective as 6 hours of patching in moderate amblyopia, as concluded by the amblyopia treatment study, and 6 hours are as effective as full-time occlusion in severe amblyopia. Near work activities for 1 hour per day with patching gave better results in severe amblyopia. Atropine penalization 1%, as concluded by the PEDIC studies, it was useful as occlusion in moderate amblyopia, but not in severe amblyopia. Once per week in the morning is as effective as daily administration with better compliance. The Bangerter filter was also studied by the PEDIC studies, and it was as effective as 2 hours of patching in moderate amblyopia. Parents reported better compliance. It can be considered as first line for treatment of moderate amblyopia, but unfortunately, the filter is not available widely in Egypt. The CAM stimulator was developed in 1978. It presents a series of slowly rotating line gratings of low to high spatial frequency to the amblyopic eye only while the child is playing drawing games over the grating. It's not widely used. Perceptual learning is it depends on the ability of the sensory system to improve its response to stimuli over experience. So training can improve discrimination of basic visual features. There is no enough evidence about perceptual learning in treatment of amblyopia. The Coptic training, amblyopia is binocular phenomena that presents with unilateral visual loss. The intraocular suppression is perceptual suppression. The image seen by the stronger eye dominates during binocular viewing, blocking the image of the weaker eye from reaching awareness. So as soon as the patch or the blurring effect of the atropine penalization fades away, the child would still prefer to use the dominant eye. There is a potential for improvement outside the critical period. I'm sorry. There are different techniques used in the Coptic training. There is the anti-suppression technique, which reduces the image contrast in the fellow eye to equal the perceived contrast of the amblyopic eye. There is also the balanced binocular viewing, which blurs the image in the fellow eye to equal the acuity of the amblyopic eye. And there's the interactive binocular treatment, which presents different aspects of a visual scene rapidly between each eye, requiring binocular stimulation to see the presented image. The problem with the Coptic training was that the games were boring, as stated by the children. So recently, in 2018, there was a new game called the Dig Rush game. It was interesting for the children to play this game. So the compliance was good. It was 55%, which is as effective, which is almost as compliant as the patching. I'm sorry. 1 hour per day for 5 days per week, plus spectacle correction, was as effective as 2 hours of patching in moderate amblyopia. Although the Coptic training is considered as one of the novel techniques, but the concept of the binocular training is not new. We had the gyroscope and the synoptophore as old methods for treatment of amblyopia. Medical treatment of amblyopia, which uses by using levodopa orally, which will be converted to dopamine, which is an important neurotransmitter. There was a study by the PEDIG, but they did not use it as a first line of treatment, so there was no meaningful improvement over placebo. However, it was not used as a first line of treatment. There's also the ceticoline, but the evidence is lacking. It has the same concept of levodopa, affecting the neurotransmitters. The compliance with the patching, as studied by the PEDIG, was 44 to 57%. With atropine penalization was 59 to 94%, which was very good, but it's not suitable for treatment of severe amblyopia. And with the Coptic training, it was around 50 to 55%. The causes of non-compliance were also studied. There were non-psychological factors, such as that the age of the child, younger than 6 years, they had better compliance. With higher dose of patching, there was a lower compliance, as in severe amblyopia, and the demographics, low socioeconomic and education level were associated with lower compliance. Psychological causes such as stress, stigma, and lack of motivation. So to conclude, screening should start as early as 3 to 5 years old. Always correct errors of refraction before initializing treatment. Children older than 12 years do not give up. Patching is as effective as atropine for moderate amblyopia, but not in severe amblyopia. 2 hours of patching is as effective as 6 hours of patching in moderate amblyopia. 6 hours of patching is as effective as full-time patching in severe amblyopia. When one method fails, shift to another one. Always do gradual withdrawal of treatment over 6 to 12 months to avoid recurrence. Levodopa is not beneficial, as stated by the PEDIG studies. Could the future be in the Coptic training? Thank you.
Thank you, Heba.
Thank you.
Thank you. Thank you.
Thank you very much.
Dina, Dr. Ghada.
I think I have a question for Heba. Have you tried the dichoptic treatment?
No.
You haven't. Actually, I think they're working on the binocular stimulation rather than unilateral stimulation, right? Or activation of the lazy eye, right?
Yes.
I think they choose certain visual acuity. Is this valid for every visual acuity or just certain visual acuity?
No, for moderate amblyopia.
So we cannot have a 660 vision and then train him with the dichoptic treatment?
In the PEDIG studies, this is what they concluded, but I'm not sure if they studied the Coptic training for severe amblyopia. I saw a few case reports about a patient. He was 40-something and he used the Coptic training, but it was a case report and the vision improved. But there's no enough. Yes.
He still has hope. This is a great person.
So there are a few case reports about improvement of visual acuity even in adults, but there's not enough evidence in the pedic studies about the Coptic treatment with severe amblyopia.
What's the incidence of recurrence after stopping amblyopia treatment? I mean, how long would you try an amblyopia therapy in general, whether patching or atropinization or even the Coptic therapy? How long would you try this, and what's the incidence of recurrence after stopping the amblyopia therapy?
Okay, the incidence of recurrence is after sudden stop is 25%. How long? It's according to the child's age. In moderate amblyopia, the hours are 2 hours per day, and for the number of weeks are according to his age. If he's 6, so it will be for 6 weeks, and then when we reassess the visual acuity. If the visual acuity improves, we can repeat, or did not even improve, we can repeat for another 6 weeks and reassess. There's no a certain cutoff for how long should we try if the vision did not improve. I do not have an answer for this, but if the visual acuity improves, we usually taper the patching or the penalization for about 6 to 12 months, but it doesn't have to be for 2 hours per day moderate amblyopia and 6 hours per day in severe amblyopia. It can be reduced.
Yeah,
but there are no
you start weaning them off the patching,
yes.
For example, or atropine, right? Because sometimes you try patching for the child and he improves so well. He gets better vision, but after stopping, or even sometimes the parents are so happy and it gives them a relief that the child has got good vision, so they stop patching. Even when you tell them just will go from 2 hours to 1 hour, they stop patching, and then they have it all one more. They go back to square one more time.
Yes, it's even with the compliance. When studied by the pedic, they stated that it was the dynamic. It decreases over time, like you said. So,
so do you try amblyopia therapy with all the patients who are amblyopes with you, not anisometropic? For example, if they correct with their glasses, okay, they are fine. But if they do not correct with their glasses and you want to start patching, do you start patching for all your patients?
You mean either patching or atropine? Yes, I always start with patching, but in non-compliant children, I shift to atropine, although it's not that available and it's not that effective as the as the pedic studies concluded. But it's better than nothing, I think. So yes, sometimes I do that after full compliance to patching.
Thank you so much. It's a vital talk, actually.
Thank you so much, Dr. Ghada.
I wanted to ask if any of our audience, if anybody has actually tried this dichoptic treatment.
Training.
I think Ahmed can answer that because he has the program for this.
Yes, we do have a trial we're doing on dichoptic treatment using the virtual reality. So this is probably the most advanced type of dichoptic treatment now. We already started like a preliminary study. Up to now, we have completed about 5 patients, and we are going on with another 8 patients. So we are roughly around 13, and I think we got an improvement of about 1 or 2 lines in most of our patients. Most of our patients were adult patients who either had previous treatment for amblyopia using patching or did not receive any kind of treatment before. But I think the results are still promising.
So, Ahmed, there isn't an age limit for the trying dichoptic treatment. That's the number one. And second of all, like Dr. Ghada said, is there a cutoff for the visual acuity, or is it depending that you are making the better eye blurred or less effect, seeing not as better or as well as the
contrast? Yes.
The amblyopia.
Actually, there is no age limit in our study. We have patients up to 30-something years, so we don't have an age limit. But the problem in dichoptic treatment, especially if you're using a virtual reality, is that the patient has to be well aligned. So this limits your use for patients only with anisometropic amblyopia. Yes, using some software, you can even try it in patients with strabismic amblyopia because you're going to shift the image in order to place it in front of the eye. You have to take in your mind that the image has to be placed on the foveus, not just stimulating one eye. So, for example, if the patient has an esotropia or exotropia, you have to shift the image in order to be on the fovea of both eyes at the same time. and there is no way to 100% guarantee this would happen in your patient. So most of the patients you try in are with anisometropic amblyopia. It's quite hard to do it in patients with a very poor visual acuity. For example, 0.1, 660 would be very poor. So usually we have patients like 0.2, 636. These patients usually tend to improve by 1 or 2 lines.
Okay. May I ask a question, please? Ahmed, are your patients females or males?
We have both types of patients. And the good thing about the software is that some of the games are more suitable for females, and some of the games are more suitable for males. So
I'm asking about this because I think females are not interested so much in Atari playing or in PlayStation. That's why I'm asking.
For example, yes, you're correct. For example, you found females tend to choose games where they pick fruits and flowers.
Dresses or something.
Yes, or something. While males are more interested in something like rackets and basketballs and things like this.
Yes.
Those types of games.
Okay.
Ahmed, I would like to ask, you said most of your patients were adults. Is there a reason for that? Is there a limit also for the age, for the children, the youngest children, that you can try with them like Coptic training? And the level also, the intellectual level and the social level of the child, does this make any difference for you when you choose the type of the game, or to choose for them Coptic training from the start?
It's not really related to the social level, but the child has to be slightly old in order to be able to understand the game and to be engaged in it. So it's quite hard to engage like a 4 or 5 year old boy in something like VR. It's quite difficult for him. That's why we are limiting it to patients who can actually play a virtual reality game. So probably the youngest would be around 7 years old. But if there's a way that we can engage younger children, we would have done it, but we're not able to.
Okay.
Okay, Ahmed, if I was to think out of the box, and maybe this training of this dicoptic training, and I know that they hold the iPad or the tablet at a close distance, maybe 30, 40 centimeters. But what about like playing like on a PlayStation, where at this, when there is more distance, then you can ask the patients who are with strabismus at a small angle, if they can wear like prisms, so that they can align their eyes and therefore allowing the image to fall on the macula, whether this is a frontal prism or whether this is a small, like 10 prism diopters, if they have a small amount of strabismus. Then would you think that the results are going to be the same if the distance is like an iPad where they hold something close, or if the training is done at a further distance?
No, actually, in the software that we're using Oculus Rift. So actually, we don't need a prism. Actually, the image can be moved in the Rift itself, in the hardware, to be positioned exactly where the deviating eye is. So it's not a problem that you cannot move the image. We actually can move the image, and we can stimulate both foveas at the same time. But the problem is that you cannot really guarantee that it will be on the fovea during the test all the time. So that's why we don't prefer using it in this type of patients. So even though it can be done, it won't be considered like the first line for me.
Okay. Thank you, Ahmed.
But you can actually move it. You can actually move the image and place it directly in front of the fovea. For example, you can measure the angle of the patient with like 20 prism diopters and put in your software that this patient has a squint or strabismus of 20 prism diopters, and it will align the image to be placed in front of the fovea of the eye.
So maybe this can actually even measure your amount of strabismus. It can measure this amount of
Yes,
squint.
but here we go in the dilemma. The subjective angle is the same as the objective angle. It's not all the same. Sometimes you measure the angle like 20 prism diopters, but the subjective angle is totally different. That's why it's not accurate.
Okay.
You probably all know this from the old sine of 4, when you use both angles and you measure the abnormal retinal correspondence by measuring the objective and subjective angles.
Thank you very much. Thank you. Thank you very much. I'm just
Thank
going
you,
to
Rasha. Thank you.
I'm just checking if there. Okay, there is a question from the audience. Heba, maybe you can answer. If there is a chance that this child may develop diplopia, if the amblyopic eye improves, and do you think an amblyopic eye can improve to surpass the normal eye and the child develops diplopia?
I never saw this, so I never even read about that. So why would he develop diplopia if he doesn't have squint? I'm not sure.
No, I actually have seen a patient like this. The patient was an isometrope, and he was never wearing glasses before. But when he started to wear the glasses and his vision was starting to improve, now he started to complain of double vision whenever he is wearing the glasses. And the only way was to get rid of the diplopia is to take off the correction from the amblyopia eye. And I could not find any explanation or any way to treat it.
Okay, so maybe diplopia is a sign of success of the amblyopic treatment?
I'm not sure, but I mean, this is quite rare, but I have seen it like in 1 or 2 patients all my life.
Okay. Any more questions? Would anybody like to ask any question? Okay, I would like to thank you all for participating and for attending, Dr. Ghada and Dina. Thank you very much for your time, your valuable insights on all our talks. And to all the presenters, thank you very much for the very interesting talks. And we look forward to seeing you in 2 weeks, inshallah. Thank you.
Thank you. Thank you. Thank you. Good night.
Thank you so much.
Thank you.